Hello everyone. So today we shall take a quick look at Stasis Dermatitis, or this type of eczema we also call gravitational eczema. So as you can see in the pictures, you see this. Someone has an eruption on the lower aspect of the leg that is a little bit eczematous, excoriated with crusting and background erythema with lichenification. We see the similar picture here. And then even in this illustration, it still shows you varicose veins with this skin that appears thin, tissue-like, and with dark patches and red spots. So this is what we call stasis dermatitis, and you're going to explain how it comes about and the different causes and how do we manage it. So it has different names. It has been called gravitational dermatitis, varicose eczema, as well as congestion eczema. So the key features here, we look at things, the signs usually. You have, oftentimes the patient will have venous hypertension, meaning that the pressure of blood within the venous systems is a little bit elevated, impeding the easy flow of blood back to the heart from the legs. So that means that at the end of it all, someone will have congestion of vasculature in the lower limbs, resulting into extravasation of lymph and sometimes even blood cells that end up into the interstitial spaces, giving you this type of picture, the edema, which sequentially gives you the skin manifestations that we call stasis dermatitis. So this condition as well can be complicated by other things like allergic contact dermatitis, in case maybe someone has venous insufficiency, but then at the same time they're putting on a shoe that has these rubber accelerators that like the parabens and the rest, and this can actually worsen the presentation. So oftentimes, most cases, they can be one of the most causes of disseminated eczema, the one that we looked at in the previous video, or the id reaction. This is one of the causes that can give you an id reaction. So when we look at stasis dermatitis, it's a common component of chronic venous insufficiency of the lower extremities. Can arise early in the chronic venous insufficiency, and it can also persist or even recur throughout all the phases of this venous obstruction condition. Oftentimes, it may be prominent in presence of with presence of venous ulcers or wounds, and sometimes it can be actually the precursor that ends up giving you the venous ulcer. So the cause has been associated with chronic venous hypertension being the primary trigger, and other contributing factors can be contact sensitization to topical therapies, as well as the the local footwear and the skincare product that someone applies. So stasis dermatitis was introduced by Philberry. Philberry is one who has described it, and the name gravitational eczema or dermatitis was introduced by Belisario. And commonly, we see that 15% of adults in Central Europe end up having this chronic venous insufficiency, and 1% have the ulcer. So when you have chronic venous insufficiency, also the prevalence of this stasis dermatitis is also a little bit higher. And it increases with age. So if you take age stratified prevalence studies, you'll find that as with increasing age, the prevalence and incidence of stasis dermatitis increases. So when you look at the pathogenesis and how it comes about, first and foremost, you'll have venous hypertension, which is caused by valvular incompetences. In this case, you have your deep veins. You know, we have that vascular arrangement where you have arteries taking blood to the lower limbs. Then the blood will be, the nutrients will be exchanged to the tissues via the capillaries, which later on drain into venules. Then venules will coalesce to form veins that are supposed to draw blood back to the heart. Remember that the veins are further classified depending on the level of the location in the skin, where we have the deep veins, which are located through the muscles down, and then you have the superficial veins that usually almost pass on the subcutaneous areas, either in the superficial or even in the deep venous plexuses under the skin. So from the superficial veins, usually blood is supposed to be transported back to the deep veins via perforating veins. So oftentimes the perforating veins, they can have valves that are incompetent that cannot actually prevent backward flow of blood. So at the end of it all, you get stasis or venous involvement of the superficial venous systems. Then eventually, you have that backflow. So that congestion gives you the venous hypertension, or at the end of it all, it gives you the edema that comes, and then eventually the stasis. And remember, you can also get obstruction of the major vessels, either with DVT, that is deep vein thrombosis, or you can get them obstructed because of maybe post-operative, where there is damage to the veins, and so many other things can also give you similar obstruction. Even Kaposi sarcoma, some vascular malignancies, Ferrari worm obstructions, and the rest can also give you Stasis dermatitis as well. So after this, then you have impaired blood flow. So when you have impaired blood flow, then you'll have slow microcirculation, capillary distension, and then capillary permeability, barrier damage, meaning that now capillaries can link plasma into the surrounding tissue as well as some red blood cells as well. So in this case, you'll have fluid and plasma protein linking into tissues, leading to edema that we see. Then you can also have a erythrocyte extravasation causing the stasis purpura, and then also hemostatin deposition. As you destroy these red blood cells, the component, the heme component gives you the hemostatin. Then you can have a microangiopathy and a chronic inflammation. Microangiopathy usually leads to the dermal inflammation, and inflammation is likely the driver of epidermal dysfunction as well as barrier impairment. Because when you have inflammation, you have immune cells coming to the area, destroying a few things here and there that ends up actually damaging and impairing the barrier. So the other thing that we often see is the pruritus that occurs because of the eczema, and then this pruritus can be triggered by repeated congestion and decongestion and release of inflammatory mediators, because you know that as you're trying to break down the red blood cells that have extravasated out of the blood cells, you need neutrophils, you need macrophages to try and break them down, and all these come with the release of pro-inflammatory cytokines, some of which are mediators of pruritus. So oftentimes we see scratching, which also worsens the pruritus because it puts you in an itch scratch cycle, that's whereby you feel the itch, you scratch, then the scratch gives you a good feeling, so it makes you get itching again, and then the cycle continues. So usually in the other signs, we see pitting edema, oftentimes on the shin. So this can be graded either grade 1, grade 2, or grade 3, which we usually call ansaka. And then we can get more pronounced usually in the evening. And then as someone elevates their legs in the morning, there is usually resolution. So you wake up with the legs which are very light, and then in the evening, the legs are very, very heavy. Then the second sign that usually is the stasis papilla with extravasation of blood. Then you get these papillary lesions, and eventually, when the blood is broken down, then you get the hemostatin deposition, which will give you the black pigmentation or the hyperpigmentation that we see. So initially, it can be mild or even absent at some stages, but later on, you get a little bit of hyper darkening, and this can also come with dryness of the legs as well as pruritus. Then as the condition progresses, then edema will extend to the distal third of the calf with a subfascial edema. So that means that now the fluid level is high, and then the fluid is also now encroaching on all the possible potential spaces in the skin, and this can actually even mimic cellulitis that we usually see, that you have an indulation, swelling, tenderness, and pain to see in cellulitis. So over time, the induction of the skin and the subcutaneous tissue and the deep fascia will now continue. If you don't intervene, it can even give you an inverted wine bottle appearance, which we usually see inverted champagne bottle, And this is one we usually commonly see it in the lipodermatosclerosis, the one we see in diabetic patients. And then you can also get a similar picture even in this case. So later on, the features that you see pigmentation from the hemostatin. You can also get the atrophic blanch, and then eventually you can develop venous ulcers. So these venous ulcers, most commonly, they are located on the medial supramalleolar region, or even from the lateral malleoli. So just above the medial or lateral malleoli, that's when commonly see the venous ulcers, as opposed to the arterial ulcers that are commonly seen on the shin and also on the extremities, on the digits, because the arterial usually due to compromised blood supply, so you get ischemia. So the ulcers because of ischemia. But in this case, the ulcers are usually due to congestion, and usually the ankle supramalleolar area is the first area where you get the edema, and that's where you get the first ulcers most of the time. So then when you get now the stasis dermatitis, which eventually comes in, it will develop with lipodermatosclerosis, and in that case, you'll have erythema, you'll have scaling, you'll get many around the malleoli. This will be around the malleoli and on the lower limbs, and then marked pruritus will set in with excoriation, oozing, crusting, as well as episodes of vasculation. Sometimes they can get blisters in those areas, especially if they get a contact sensitization. Then later on in the chronic phases, you can get lichenification. When you get chronic lesions, and they can end up with ulcer. Still, these ulcers will be oozing with erosions because of the scratching. And then when you get secondary, you can also get secondary sensitization, where someone now reacts to their own serum that comes from these wounds. Then you can get symmetrical eczema patches on contralateral legs, either thighs or even the upper extremities. So you can also get an id reaction that can spread to involve the trunk and the face and the rest of the body. And you see the stasis dermatitis is one of those eczemas that can actually cause the autosensitization, or what we call the id reaction, or what we call the generalized eczema. So when you take off a biopsy, you will see that in stasis dermatitis, you see the orthokeratosis. Now this is because of the lichenification, and then you see some minimal spongiosis as well. I told you spongiosis is this whitish that you see in between the cells. That is usually a intracellular edema. If you magnify more, you'll find that you can even see the bridges in between the cells. So this is what we are talking about here. So that is the intracellular edema. That's the spongiosis, as well as this lymphocytic infiltrate as well. So if you are to look at the pathogenic factors here in the stasis dermatitis, this table tries to actually summarize them for you. You will find that you have chronic venous insufficiency, and then also the microvasculature. So in this case, you'll have deposition of proteins, particularly fibrin, and then this will be deposited around blood vessels. At the end of it all, then you have this one can inhibit oxygen diffusion as well as the metabolic exchange, and this will now complicate to give you edema. Then you have slow blood flow because of the congestion and maybe the obstruction, and the backward flow of blood in the veins if you have incompetent valves. This one can cause the upregulation of the ICAM and then the VCAM1 on the endothelia. Because of this, we have now activation of neutrophils and macrophages to try and calm down the inflammation, to try and address the issue. They'll bring with them inflammation and destruction of the blood cells. And then you can also have expression of the L-selectin on neutrophils, and then the neutrophils that are attracted into and trapped within the area, notably usually the medial submalleolar region. So in this case, as I told you earlier, as you're having this congestion with blood extravasate into intracellular space, that triggers an inflammatory response. And this inflammatory response calls upon recruitment of neutrophils, lymphocytes, to try and address the situation. So these ones will come in with their inflammation and the rest, and that's the picture you will get. Then eventually we can have use of inflammatory mediators and free radicals as well as proteases by the neutrophils, and this usually give you the precapillary inflammation or inflammation around the pericapillary, around the capillary network, or even the venules. Then you can have free iron, which is released from the hemostatic deposits, and then this iron will increase the iron-free radical production and lipid peroxidation, and this one can also activate the matrix metalloproteases, which will now come down and break down, which will come in and then break down the collagen and the rest. So you see now we are having now tissue destruction because of impaired blood flow. So then later on, you'll have now platelet accumulation. You know that every time you have stasis in a vesicular tube, you'll end up with aggregation of platelets and forming of clots. So this will also come in, and this can also trigger local thrombosis. Then fibrosis and tissue remodeling comes in later. That gives you the lipodermal sclerosis and also the lymphatic dysfunction. That gives you the atrophic branch. In the atrophic branch usually gets satellite sclerotic areas, which are deposited of capillaries with the formation of peripheral giant capillaries. This may lead to formation of venous ulcers as well. Then you can also have elevated plasma levels of homocysteine, and this has been thought to be associated with an increased risk of thrombosis. That can also give you now a PE, that's pulmonary emboli, or even thrombus that can be thrown into the heart. Then we have factors that can complicate this stasis dermatitis. The first one being allergic contact dermatitis, with either things like linolene derivatives, emulsifiers, antiseptics, and the rest. This can cause sensitization that can actually worsen the stasis dermatitis. Then you can have things that can cause irritation. Those that cause irritant contact dermatitis. The other ones cause allergic. These ones cause irritant. They can also worsen the condition. So depending, it can be acids, it can be bases, it can be alkali that can also irritate the skin, making the dire situation worse. So we have cutaneous signs of chronic venous hypertension that include edema, oftentimes tender, and then varicosity. Someone will get engorged blood vessels behind the leg. Those are called varicose veins. You can have petechiae. This is usually when you have a bleeding under the skin. And then you can have stasis dermatitis, lipodermal sclerosis, and then ulcers, as well as angiodermatitis, which is also called the pseudocarposis sarcoma. In some cases, you can end up with livedoid vasculopathy that gives the atrophic branch. So in this picture, this is how the patient will look like. So initially, you just have you'll have the edema of the lower limbs, but now at the skin will be okay. So as the disease progresses, then you can have papillary lesions, you can have edema. Then later on, you get hyperpigmentation as you have hemostatin deposited under the skin. Then later on, if you don't address, then that's when you end up with the dermatitis, the stasis dermatitis. Then later on, you can now develop the ulcers and the rest. So what should you think about if you are suspecting stasis dermatitis? The stasis dermatitis is usually easily diagnosed when the signs of venous hypertension oftentimes evident. So someone has engorged veins on the legs. At the same time, they have edema. Then they have this hyperpigmentation due to hemostatin. Then they have itching in the area. So that will be easier for you to make a diagnosis of stasis dermatitis. Then the challenges come in if you are to differentiate it from other conditions like this acidotic eczema, irritant contact, allergic contact, pneumonia eczema, psoriasis, and even mycosis fungoides affecting the lower limbs. So that's when you have now to open your mind and then see what accounts for each condition that you may be suspecting in this state. So in terms of treatment, the treatment goal is usually to manage the venous hypertension that we shall review in this chapter. And in this case, you can use things like compression, bandages, calf muscle exercises, limb elevation, compression soakings, which are graded with different pressures. And then you can also do lifestyle audit, and someone also has to adjust their lifestyle. They should stop smoking, then do weight loss, and and try to address all those features. Then in the surgical approach, if needed, you can also do what? You can operate and then see if you can reduce on the venous obstruction. So topically, we can give corticosteroids as for other eczemas as well as emollients that are a little bit low on sensitizers. Then if the patient still persists, we may now need to manage this patient with a cardiovascular surgeon. So thank you very much. That was our brief on Stasis dermatitis, which we also call the gravitational eczema.